renal dysfunction as well. So I did not put it up as an MCQ question. So basically, you all know, patient like this comes, you manage it on daily basis. You diagnose this patient with Lasix. You can give spironolactone to this patient. ACE-ARB optimization means that you have to up the dose so that you can have a better control on your blood pressure in these patients. Can we give ARNI to this patient from a heart failure perspective? Anyone? So ARNI is not indicated for patients with normal ejection fraction. So that is where we want. For these patients who have reduced ejection fraction and clinically overt heart failure, they are better candidates from this point of view. Now, heart rate control, initially you want to diagnose the patient, you give them long-term beta blockers. Sometimes you need help with ibuprofen so that their heart rate is in 70s or so. SGLT2, what dose? 5, 10, 12.5, 25, because in diabetic patients, you have all these options. And we're going to answer this question as we go along in the presentation. Last one is mitral valve surgery after ischemia workup. And the reason I brought it up was that many times we are seeing echocardiographic reports, but we don't pay attention to so many numbers in it and the findings about valves. Someone with a mitral regurg, normally you expect the ejection fraction to be hypernormal, like 80%, 70% like that. Someone having a 60% is already showing as if the heart is failing, and the heart is dilating at the same time. So these are the clues that if the systolic dimension of the heart is more than 40, this is the time to actually think about sending this patient for mitral valve surgery. Once the EF starts going down to 45, 30%, then it's too late. So this is why I brought this case. This is one of the most common presentations that we see. These patients end up in emergency. You give them Lasix in the morning, and they get better, and you send them home. But if you miss this, the outcome is not going to be good, and this patient is going to be back in emergency in hospital within a month. So that's why in heart failure patients, re-hospitalization has become one of the major indicators that is tagged in the studies for all the trials. Case 2. So all these are one-page cases, and they have 1 or 2 teaching points, and then we can go ahead and just complete the presentation. I'm not going to take too much time. Case 2 is 60-year-old, same female, same history, same blood pressure, same examination, but over here the ejection fraction is 30%, heart is still dilated, and 2+ MR. This patient's creatinine is high, 3.5, and potassium is also high. So we don't want to give spironolactone to these patients. So make sure that when you are dealing with diagnosing these patients, this is something in your consideration that not all medications can be given to all patients. Of course, once this high creatinine and this high potassium, your ACE, your ARBs, your ARNI, they can't be given. So your option is nitrates and hydralazine in these cases to reduce the afterload, so that your mitral regurg is reduced, and then the LV is not going to get dilated beyond that. So you can slow the progression of disease in this patient. So for heart rate control, beta blocker ibuprofen is the same, SGLT2, but this patient is late for mitral valve surgery. So it's only for medical therapy, and that's a palliative care for this patient, unfortunately. Case 3. 60-year-old obese female, same history, same examination. So on this patient, echo EF is 45%, but heart dimensions are normal, and there is MR. Potassium is okay, creatinine 1.5, but troponin is positive. So this patient comes in with heart failure with shortness of breath and PND. So of course we're going to diuresis, we're going to give ACE, ARBs, heart rate control, SGLT2. But with troponin positive, make sure that this is the time, and your 1.5 creatinine should not stop you from doing angiography and correcting the ischemia. Many of these mitral regurg are ischemic MR. So once you reduce their ischemia, the MR gets better, the heart failure gets better. So that's something that is a learning point from this case 3. Unfortunately, Majority of our patients are non-ST elevation MI. So these patients actually present with comorbidities. They come to ER, but since they are sick, we tell them, okay, we can do angiography at this time, let the patient be stabilized. And once patient gets stabilized, which sugar most of them do, then you don't want to do an invasive procedure. But once the creatinine starts going up more than 2, then it becomes a more difficult decision to take a chance for the kidneys for this patient. So don't miss the boat while you're managing these patients with heart failure. Case 4, same first line and same second line, except patient is already taking Lasix 80 and is still in heart failure. ECG has LPH. On echo, the ejection fraction is 20%. Heart is dilated, there is MR, creatinine is a little higher, potassium is okay. So these are the patients that need to be hospitalized. So this is decompensated heart failure, because once there is enough sarcoid edema, the hepatojugular congestion, ascites, edema in the legs, the medicines that they take orally are not being absorbed, because even the intestinal mucosa is edematous. So these patients actually require IV diuresis. And once they diurese good 3, 4, 5 liters, then the oral medications can be effective for this patient. So but many a times you can't give them ACE, ARB because the blood pressure is so low in these cases. The vitamin support is required for heart failure patients. Heart rate control, ivermectin can be given because of low BP. Many a times you can't give them beta blockers also. And SGLT2 can be given to these patients. But remember, SGLT2 is not a medication for an acute decompensated heart failure. It's a medication which takes time. So its effect will start showing up after 4 to 6 weeks. And this is the medication that you want on these medications for up to 6 to 8 months, or as long as they can. Take it safely. Last case, 60-year-old female. Now this female has asthma. So we don't know whether the heart failure or asthma, which one is making the situation worse. High heart rate, high blood pressure, GBP is high, rails are there, edema is there, and this patient is on high dose herbesser because of asthma, beta blockers are not being given. So you diurese them to make them better so that they can lay flat. This is something that we keep missing on our patients' prescriptions, that calcium channel blockers cause fluid retention. So be wary of this fact and make sure that if somebody is coming with fluid overload, there is no calcium channel blocker, because calcium channel blockers in high doses retain fluids and makes the heart failure worse. So this is what needs to be identified in most of your patients. So these are a couple of practical points that I wanted to discuss with you. When you compare SGLT2 with furosemide, furosemide is something that works on the loop of the nephron, while SGLT2 is a proximal cholinergic tubule. They both cause diuresis in a different way. One is furosemide, which over the period of time develops resistance. So many times you have to give different loop diuretics. Metolazone is something available. Bumetanide is also available. So many times you have to revert to these because they don't respond to Lasix that much. While in SGLT2, we don't see much of a resistance. Your intravascular compartment gets more contracted by giving furosemide. So these cases actually, the patients get low blood pressure and they actually start getting more weakness and they're getting more cramps in the legs. While SGLT2, being an osmotic diuretic, not a natriuretic drug, it actually gives your patients better quality of life, but it takes time for it to work. It has, like Dr. Bilal has already emphasized, a multifaceted effect. It works on kidneys, it decreases plasma volume, decreases myocardial stretch, decreases stiffness in the blood vessels. Metabolically, uric acid goes down, so for metabolic patients, it's a good medicine. Hemoglobin A1C goes down. So all these eventually leads to better cardiac and renal outcomes for your patients. When you see the heart, initially when the heart failure is there, the muscle and the interstitium is very congested. And over a period of time, by giving SGLT2, the chambers normalize. They start to get remodeled. And it takes about 6 months for the heart to get to almost normal shape. And that we can actually see on an echocardiogram on these patients. The arterial stiffness also, because if you give loop diuretics, what it does is it reduces the intravascular volume, so your arteries are contracted, and that's how osmotically you're reducing edema in the interstitium. Well, that's not the case in SGLT2, so your intravascular volume is actually preserved in these patients, and they don't get that much hypotension with this medication. So this is the same thing that we already discussed, so I'm not going to go. So not all medications is for everyone. On one hand, we know the benefits of SGLT2, but make sure that your type 1 diabetics should not be given this. Anyone with genitourinary infections, decay, fractures, volume depletion, acute kidney injury, SGLT2 is not for those patients. So when clinically you are seeing these patients, make sure that you keep this in account while you're making decisions for your patients. MREC trial, Dr. Bilal already has discussed a couple of factors in this. From the trial, it was trialed on 7,000 patients. They gave 10 milligram and 25 milligram empagliflozin, and there was a placebo group which was given all the standard of care medications for the control of their diabetes and cardiovascular disease. So the inclusion criteria had these two: that adults with type 2 diabetes and established cardiovascular disease. They were not very big.